Up to 75% of women experience severe vasomotor symptoms, like hot flushes and night sweats. Add in sudden anxiety and severe bone loss, and the scale of this biological disruption becomes clear. Medically, a doctor cannot diagnose menopause in real time. It is defined as the permanent loss of ovarian follicular activity, and it is diagnosed retrospectively only after a woman has gone 12 consecutive months without a menstrual period. The median age for this milestone is 51. This chart illustrates the hormonal trigger driving that milestone. As we move left to right on the timeline, from pre to postmenopause, you see a steep drop in the hormone estradiol. In response to that vacuum, the pituitary gland overcompensates, sending levels of follicle-stimulating hormone, or FSH, and luteinizing hormone spiking upward. Expanding this timeline reveals how the consequences map to these changes. Acute issues like severe hot flushes and insomnia cluster right around the initial estrogen drop. Further down the timeline, chronic risks begin to escalate, including osteoporosis and cardiovascular disease. Because this hormonal vacuum affects multiple organ systems at varying degrees of severity, a generic one-size-fits-all prescription will fail. Managing these risks requires an individualized clinical approach. Before introducing synthetic hormones, physicians establish a baseline defense. This involves modifying lifestyle risk factors like smoking and high caffeine intake, alongside prescribing weight-bearing exercise and calcium supplementation to protect skeletal health. Once those foundations are set, physicians look at the specific clinical profile of the patient. The first profile is the perimenopausal patient. She is experiencing disruptive hot flushes, but she is still having irregular menstrual cycles. Doctors prescribe sequential HRT. A 28-day circular chart shows the regimen. Baseline estrogen is taken every single day. Crucially, a second hormone, progestogen, is introduced only during days 15 through 28. This protects the uterine lining from hyperplasia. Stopping it triggers a predictable withdrawal bleed. For a woman still in the reproductive transition, mimicking her body's natural endocrine cycle offers systemic relief from hot flushes without increasing uterine cancer risks. The calculus changes for our second profile, the postmenopausal patient, who is over a year without a period, or the hysterectomized patient. Because postmenopausal patients no longer need a monthly bleed, they receive continuous combined HRT, taking both hormones daily. If a patient has had a hysterectomy and lacks a uterus entirely, the progestogen is dropped, leaving estrogen-alone therapy. Our third profile is the localized symptom patient. She does not suffer from systemic hot flushes. Instead, her complaints are strictly urogenital, presenting as vaginal atrophy or urinary urgency. Exposing her entire body to systemic HRT carries unnecessary risks. Instead, physicians bypass oral pills in favor of topical vaginal estrogen. This targets the atrophied tissues directly, offering high efficacy with a much safer long-term profile. Finally, there is the contraindicated patient. Due to absolute medical barriers, like a history of breast cancer, active liver disease, or a recent heart attack, hormone replacement is completely off the table. Physicians manage these patients through alternative pharmacological routes. A low dose of the antidepressant fluoxetine is used to suppress vasomotor symptoms, while targeted drugs like bisphosphonates are prescribed to halt bone loss. Prescribing HRT is a complex exercise in risk versus reward. The exact choice of drug, dosage, and delivery method must align perfectly with the patient's anatomical status and medical history. The golden rule of prescribing is clear. If quality of life is heavily compromised, hormone therapy is medically justified. However, doctors must utilize the lowest effective dose for the shortest necessary period, typically 2 to 4 years for controlling vasomotor symptoms. Because HRT interacts with multiple body systems, patients require an annual medical review. Doctors will check blood pressure, run lipid profiles, and conduct routine mammography to ensure the therapy remains safe. During treatment, any abnormal vaginal bleeding, such as unexpected breakthrough spotting after months of amenorrhea or a sudden heavy bleed, is a major clinical red flag. It requires an immediate ultrasound or biopsy to exclude malignancy. Medical intervention is designed to stabilize the body during a chaotic phase. It is a highly monitored, temporary bridge rather than a permanent lifelong crutch. Ultimately, menopause is a singular event within a broader transition known as the climacteric. Much like puberty, it is a massive, natural, biological remodeling, shifting from a reproductive to a non-reproductive state. Navigating this remodeling requires clear data. Patients must track the frequency of their symptoms, compile their exact family medical history, and bring that evidence into the consultation room. By understanding these distinct clinical profiles, you can actively partner with your physician to build a customized, evolving toolkit for your total body health.